today's topic is the surge capacity, and this is an interesting topic because till about 2 years back, when we talked about surge capacity, it was considered that we may never really need to activate in a manner in which it is being discussed. But ever since COVID has come, we have realized that this is one aspect of our hospital management where we really need to have a very clear understanding of how it is done. So, a full scale session on a subject like surge capacity will require about 2 to 3 hours of discussion and presentation. So, what I'm going to do is I'm going to cover some salient aspects and talk about the basic principles which are necessary for critical care provisioning as far as the surge capacity is concerned. And we will then see what are the important elements for a hospital plan that should be there in every plan before we can respond to such situations. The next important thing will be that, rather, the next important thing is that we are going to share some of the resource material, so there is sufficient material for everyone to read for some time. The idea is to understand this whole thing on a conceptual basis, understand the principles of it, and eventually, when we make a plan for the hospital, which normally is in the form of a disaster plan for the hospital, then we incorporate as many elements of the surge capacity planning and creation into the plan, so that when the need arises, we are able to respond. Because this is what will be the test of the plan or the proof of the pudding. So if you are not able to respond, there is no point having a plan. So therefore, a plan that works is better than a great plan that may not really, or that does not work. So with that little background, let's look at the scheme of presentation for today. So we'll discuss a couple of aspects of what is surge capacity and how we understand it. Then we will look at the surge estimation models. I think we've covered in past, and I'll also repeat it today, that all the disaster management, as far as hospitals are concerned, where the hospital is a responder to a disaster event, there is one aspect which is common everywhere in every situation, and that is that the hospital will end up handling a much larger number of patients than it normally handles. So the moment we say that it is going to handle a much larger number, we are looking at number of patients who will get cared for by the hospital. Now, in a situation where we don't know this number, we will have to have some method to figure out as to what is that number for which we do the planning. These estimation models are essentially the models which incorporate multiple parameters and give you an estimate of case loads or casualty loads or similar numbers. And those numbers are then used for planning purposes. Now, this is not to say that the estimation models will give you exact numbers. They can never possibly give you the exact numbers. But what they give you is a starting point. Because if suppose you are let's say you are a 1,000-bedded hospital, a big, nice, super specialty medical college hospital, and if you have to plan for a surge event, for example, a disaster or something similar, then what is your planning parameter? I mean, how much resource are you going to designate for responding to a requirement like that? Now, this will depend only when we know the numbers, and these models are useful to the extent they give us a estimation number, which may not be really accurate, but it is a number based on which you can do a planning. And then subsequently, based on the experience in a real event, we can modify the estimations either upwards or downwards, and then prepare accordingly. So the estimation models have a role where these are useful for getting a number based on which we can do the plan. So the sample plan that I will be sharing on the Rafa Learners portal will have a, a calculation sheet where you put the numbers and then you can accordingly figure out what is the logistics or what are the resource requirements. The next, we will also look at the critical care surge capacity principles. So these are the principles which were published in the journal CHEST. I'm going to share the link to that journal as well, and it is also one of the downloadable resource that we are sharing today. So that gives us the principles for planning for critical care. I am addressing only the requirement of critical care in a surge situation, uh, because the critical care by far is the most complex part of providing or responding to a surge event. Uh, Non-critical care, or for that matter, obviously, if you have X number of critical patients, you will also have 3x, 4x, or maybe 10x number of patients who are not critical, but they do require medical care. As we have seen in COVID pandemic in over last about year and a half plus, that for the very large number of patients in the community, the critical care will possibly be required by, let's say, 2% of the total patient population. And this 2% will be in the hospital. That is where the maximum capacity constraints or maximum issues related to the care logistics come. The issues are also there as far as the care of other patients are concerned, but we are not covering that today because obviously we have limited time, and in this only so much can be done. So maybe on another occasion we will look at the how to handle or how to address the surge requirements for patients who do not require critical care, but they do require care. So we can't ignore them, but today we are not discussing that. And lastly, we will see what are the elements of a hospital, excuse me, a hospital surge plan. Now, these elements are this I've taken from a checklist for disasters from, and it's a WHO publication, easily downloadable. I'm going to share that as well. It's a beautiful checklist. If you implement that, you would have covered every possible aspect of a good plan. So that is how it helps us in preparing a plan for the hospital. Eventually, since this plan will be based on the estimation of the patient numbers that will come from the estimation models, so we will need to tweak it subsequently. So in one iteration, for example, in one experience, you think that if you find that your logistics arrangement were more than sufficient, or rather you over provisioned, then you can, for the future planning, you can possibly scale it down to the level where you think is appropriate. If you have fell short of the resources, then obviously you'll have to scale up. So this is something that will come from the experience, and this will need to be, it's a continuous, it's a iterative learning process. So with each experience, we refine our model and become better. We refine our plan and become better. So with this scheme of presentation, let's look at what is a surge capacity. So this is a primary requirement that the medical and the public health systems must prepare for major emergencies or disasters involving human casualties. So we talk about industrial disasters, we talk about natural disasters, we talk about pandemics. So any of these situations, they will require the health systems to respond. So such events obviously severely challenge the ability of the health system to adequately care for large number of patients, because even in a best of a situation, if the number of patients go very large, it will overwhelm the system. And if you recollect the rationale for the lockdowns for COVID-19 pandemic, the rationale has always been that you are putting the lockdown or you're implementing lockdown so as not to overwhelm the system, the health system. So you implement a lockdown so that the spread of infection reduces, so that the number of patients reduce, so that the health system is able to handle the number of patients that the community has. So this number of patient is essentially a capacity, which is a problem of scale. that you can handle 1,000 patients today. Can you handle 10,000 tomorrow? So this is a requirement of scale, that can you handle this number? This is about the surge capacity. The other aspect, or the other term that is that is used in reference to a surge is surge capability. Now, this capability will depend on the kind of patients that you are handling. So, if you are planning, or if you are preparing for industrial disaster, for example, gas leak, if you take the example of Bhopal gas leak, the requirements of a patient in such a situation is different from a requirement of patients from, let's say, a road traffic accident or a railway accident or earthquake possible. Similarly, if you have a pandemic situation like it happened with COVID-19, the kind of care or the kind of specialization skills the COVID-19 patients required is obviously different from what a trauma patient will require. So this is about the capability, which will be different for different kind of patients that you are going to address. So we have to look at both the scale at which we operate and the kind of care, the specializations that will be required, the skills that will be required for providing the care at that scale. So the mass effect events or the mass casualty events have varying degree of impact on various sections of the society. Now, people with the limited or no access to healthcare suffer the most, obviously, because you have the largest numbers there, and therefore the human impact or the suffering is more in terms of numbers there. So the preparedness depends upon various critical pieces of information. The first one is the estimated number and the type of casualties. We talked about surge capacity, we have talked about surge capability. So the number and the type of casualties. The next is the time frame over which this will occur. Now, if you're going to get the patient, trickling into the health system over a period of long time, then possibly one is not really concerned too much, because your system or the hospitals will be able to take care of whatever number of patients that come slowly over a period of time. But if the event happens to be catastrophic, or it happens in a very rapid progression, for example, we have talked about COVID-19 waves. So the second wave, typically, if you look at the situation, what was there in the April 2nd and 3rd week this year, you have a large number of patients suddenly appearing, or suddenly a large number of patients in a very short time frame. In an event like earthquake or a similar natural disaster, you will have actually a point event, that it happened today morning at 6 o'clock, and suddenly in one event only you have a large number of patients. So time frame is important, because time frame will decide as to how are you going to respond to it, whether you can scale up, that is, you handle your capacities incrementally over a period of time, or you are going to be required to suddenly respond to a very large number of patients. The preparation will be different for these two situations. Okay. So the next is the characteristics of the event, and we've talked about it, whether it is a pandemic or a disaster. So depending on what is the event, you will need to respond in a different manner. And that is the reason when you make a disaster plan for the hospital, you can't have one template and say that, okay, anything that happens, we're going to implement this template, because that template will not be suitable for every contingency that you are possibly preparing for. So therefore, one of the key elements for the hospital plan will be, and we will come to that towards the end of this presentation, that you identify what are the possible contingencies that you will be required to respond to, and accordingly prepare. You can't prepare for everything that is possible under the sun. That's the key message that we need to know. So all public health, at the public health level, it is important to have a good estimate of number and type of casualties and the time frame over which it will occur. So if you are following the COVID-19 updates that the Ministry of Health and Family Welfare in India is giving on a regular basis, you would have seen that there is a task force at the national level and there are task force at the state levels. And these task force are keeping a very close track of the number of patients that are popping up everywhere. So there is every day there is update on the positivity rate or the R0 number or the number of new patients, number of total patients, number of deaths. So this kind of data, this kind of information is being not only generated on a regular basis, but it is also being shared among the professionals, among the healthcare fraternity, as also with the public at large. So this is what helps in planning. Second thing, using these numbers, you can also have a fair idea of the time frame over which you are going to, or rather over which you can expect that you will need to activate your hospital uh, disaster or hospital plan. So these two bits of information are important. So this will help in appropriate public health response, which must be mounted. I have talked about it, and usually you will find this response will be at a level of a community. It is never, very rarely it happens that one hospital will respond to a large scale disaster. You will need to respond as a community, which means all the hospitals in that area will get activated. The governments will get involved. The district administration, the state administrations will get involved, and they will have a view which or guidelines or the policies that they frame will need to be implemented at the level of hospitals and at the level of communities. So what are the methods of estimating the casualties? So there are various models, and there was one, in fact, if you look at the CDC website, CDC, that is Centers for Disease Control, it's a US organization, you will find there are calculators. So you calculate the estimated number of casualties based on certain parameters, and they will ask you for those parameters, and based on that, they give you a number. So there are various models that exist for estimation of casualties, and this obviously depends event to event. So for an event like a cyclone or a tsunami or an earthquake or something of like a natural disaster which happens over a very short period of time, you will have a different method of estimation of casualties, whereas situation of a pandemic will have a different method. So obviously the models will also be different for different contingency requirements. The bottom line remains that we are striving to get a number based on which we can plan at the level of community and at the level of hospitals. And this number, the estimated number, is given by the models, and there are various ways of calculating it. So what I'm going to do is we're going to talk about the COVID-19 models which are currently available. And we will also look at the principles for critical care surge capacity for COVID-19. Why I'm using COVID-19 as an example? Because this is current. This is our, current problem at hand, and we are still not out of it. So it will be a good idea that we understand it and we use this as an example. For each of these 6 or 7 models that I'm going to display on this slide, you can have a search. There is an article that I will be sharing along with the downloads today. You can have a look at that. They have compared the models and they have given the methodologies as to how they work. For each of these, you can actually calculate. Many of them give you a spreadsheet, so they actually give you an estimated number and a time frame over which it is going to, it can happen. So the first one is called the Cornell COVID-19 case load calculator, and it calculates the capacities that are required and the ventilators that will be required. The next one is called COVID-19 acute and intensive care resource tool, hospital impact model for epidemics, COVID-19 ICU and floor projections, COVID-19 surge, and COVID-19 surge is a CDC estimation model, surge capacity bed management tools. So there is an article that I'm sharing because it will not be possible for me to really discuss the entire article in a short presentation like this, but this will be available and you can easily understand how these models work. What is important is not to get hung on a particular model. Eventually, each model is what is it trying to tell us? It is trying to tell us that this is the number that you will be handling. So this number, let's say for COVID, we have a fantastic model, and over a period of time, this calculation methods have also matured. But even in a disaster situation, which is very unique to a particular hospital, the hospital can have its own method of estimation of casualties for a given contingency that for which you are planning, and accordingly, based on that number, prepare. Now, obviously, it is not to say that this estimation number is going to be an accurate number, or it is required to be an accurate number. This can never happen. So eventually, one learns over a period of time, but you need a starting figure based on which planning can be done. Now, this is another aspect that we need to understand, and this is what is called the surge capacity spectrum. Now, this talks of surge capacity at three different levels. The first level is the conventional capacity, which is implemented in a mass casualty incident, and it represents care as is usually provided at the institutional level. So, for example, let us say there is a train accident, and you have, let's say, a certain number of casualties, maybe 120, 150, or 300 casualties. Now, these casualties will all be treated in various institutions, and you are providing care as is usually provided. So, essentially, there is no compromise on the quality or the level of care that is being provided. Now, this is applicable for a major mass casualty incident where you have X number of patients. However, this number is not enough to really overwhelm the system. So maybe one hospital will get overwhelmed, but at the level of a community or a region, for example, if you take the number of hospitals in a district, and if all the hospitals pool their resources, they will be able to handle the number of casualties that will happen. So this is conventional, where there is a mass casualty event, but the level of care is same as it is being provided otherwise in the institutions. The next one is called a contingency capacity. Now, this contingency capacity means that we are forced to compromise on spaces. That means we have more number of patients than the number of beds that we have. We are forced to compromise with staffing constraints. So we will have staff, less number of staff for the number of patients that you're going to handle. And you have supply shortages. So you run short of oxygen, run short of beds, run short of linen, run short of medicines, etc. So this is contingency capacity. This is a level more difficult to handle than the conventional capacity. And the next one is called a crisis capacity, where it is a catastrophic situation and the entire health system gets overwhelmed. Let's say, in a district, all the hospital, or in a region, all the hospitals get overwhelmed. So therefore, you are not able to provide even a minimum level of care. There is a significant impact on the standard of care. Though it is not available or not discussed in our context in India, but there is something called altered standards of care. So altered standards of care is a concept that we can discuss sometime, but let me very briefly mention it here, where you have a situation where some people will be denied care, despite the fact that they may be needing it. Now, what is the criteria for denying care? The easiest one that comes to mind is the triage. So where you have, let's say, a large number of casualties, so you do triage and you decide, okay, this is the person who has the maximum chance of survival, and therefore he gets a care, and the other person who may not have that high chances of survival, he may not get a care. This is a very contentious issue, very politically sensitive at the level of community, not easy to decide on. But there are countries where they have altered standards of care, and these standards are usually invoked by using the law of the land or by using a mandate by the governments. Because eventually, once you deny care to somebody based on any methodology or any parameter, for example, a triage parameter, you need a statute, you need a law of the land to back you up, to hold your hand that yes, you denied care and therefore this person suffered. Now tomorrow you shouldn't be taken to task that why did you not care for such a patient. So therefore, altered standards of care is something where you deny care based on a criteria. Not applicable in our context. We haven't discussed this in any of these forums, but this is something that is there in many countries. You could have a look at it. Altered standards of care, if you search, you will find, and we will surely have a discussion one day in this session as well. So when we talk about crisis capacity, this is where the system is really inundated with patients. It is a kind of a catastrophic situation, and you have a significant impact on the standards of care. So these are the three levels of surge capacity spectrum for which we should be planning. And your estimation models, whichever you are using, whichever model you use, whether the existing model or you have your own method of estimations, you must cater for these three levels of capacity spectrum, because then only you will be able to, or you'll be in a position to really respond to it well. Okay, so now next we come to the critical care surge capacity principles. If you have questions, I'm sure there will be many, so please put it on the chat box and I'll take them, take all of them one by one towards the end of the presentation, or after I have finished. So critical care surge capacity principles, this is there in the journal CHEST. I'm giving the link to that article as well, and it is also available as the download. So please have a look at it. It's a good read and also gives us a lot of understanding of how this can be done. So the first one is the role of critical care in disaster planning. Typically at the level of community or the level of government, if you look at the planning parameters that are given at the National Disaster Management Authority's website or the documents, the critical care is not specifically addressed, though it is part of the overall planning. But we realized, I think, in COVID-19 pandemic last year onwards, that the requirement of critical care can become a stumbling block in the entire scheme of things, and hence this article in that journal CHEST, and hence I'm including it here in this presentation as well. So the first principle is include a critical care expert to optimize the critical care surge capacity planning. I think it's simple to understand that you need somebody who understands critical care, who can figure out what all he can figure out, who can figure out the skill levels that you will require. Many of you who are tracking COVID-19, and all of us are in some way tracking COVID-19, you would have seen when we talk about the third wave in the country, we say that the pediatric population will be affected, and certainly there is a lot of noise about how are the skilled people available to handle the critical care requirement in the pediatric age group. So obviously these aspects will need planning, and therefore a critical care expert is a good idea to have. So one of the requirement is to have a critical care expert in your planning team. This is the reference to that article, and it is also, you can use this reference, or you can see the download that will be given. The second is about the surge continuum. So we talked about the conventional, contingency, and the crisis in the surge spectrum. So we need to use one such framework for estimation of casualties, which covers these three thresholds, because we will need these numbers. You can't say that we didn't know. So therefore, we need one such framework which will give us these numbers. Then we have to have targets for the surge response. Now, this target obviously comes from the number of patients that we're going to address. So for a slow onset impending disaster or a threat, you have a number of cases slowly building over a period of time, let us say 15 days to a month or month plus. The targets for surge capacity will be focused on the projected loads. If you recollect how the state governments and the central government responded last year to the COVID-19 pandemic beginning March, in the month of March 2020, the response was scaled up in line with what was projected. Of course, many times the projections didn't really go as what happened on ground, but the response was linked to the projected numbers. And therefore, this is one way where you have a pandemic or a situation evolving or developing, building slowly. You could track the projected load and respond to that level. So for a conventional response, you must be able to have, or you as far as critical care is concerned, you should be able to immediately expand by at least 20% above your baseline capacity. So if you are at 20 bed, if you have 20 beds in your ICU or you have 20 critical care beds, you should be able to address 24 patients immediately without any additional or external help. This is the minimum requirement that is there. At the next level, at the contingency response, we need 100% above the ICU baseline capacity. So if you are a 20-bedded hospital, 20-bedded ICU or critical care beds, in the contingency phase or in the contingency response or a number which is equivalent to a contingency response, you should be able to provide care to 40 patients, which is 100%. That is double of 20 that you have. Now, this obviously will not be possible from within the internal resources of the hospital, and therefore there will be a requirement to pool the local and the regional resources. Now, this can come from various methods. For example, you have the private doctors or private practicing doctors being recruited into the system. You have additional recruitments. You have assistance being provided by the institutions which are outside the pandemic area. You may have situations where the armed forces or the army doctors provide assistance. So any such assistance which comes from the outside. The third one is the crisis response, which needs to be at the level 200% above the baseline ICU capacity. So this is for the critical care, and when you have, this is the minimum that you should be preparing at the hospital level. The total number of casualties requiring a crisis response may be far more, but at a hospital level, if you have a 20-bedded hospital, 20-bedded intensive care or a critical care facility, we should be able to address 60 patients. That is how the principle is defined, and that this obviously will not happen without the help. So this help will come from local resources, regional or national resources, or international help also sometimes comes. So therefore, these are the three levels for which we need to plan. But at the local level, when we are planning at the conventional level, 20% above the ICU capacity. This I'm talking about only critical care. We are not talking about other patients at the moment. Contingency response at 100% above the baseline ICU capacity, and critical crisis response at 200% above the baseline capacity. Prolonged demands on critical care compared with the demands placed on other sections of the hospital be taken into consideration before resuming routine activities that may require ICU support. So typically what happened, if you recollect our own situation during the first and the second wave, the COVID and the non-COVID care was in a way segregated. So we had COVID hospitals, we had non-COVID hospitals, or within a large hospital, COVID centers and the non-COVID care. Now, when you are returning to routine activities, then you need to consider what is the impact of critical care, the demand for critical care, and this will, this needs to be addressed in a different manner. In one of the sessions, I think a couple of weeks back, we talked about non-COVID care framework, and that framework is available in the recorded sessions where we talked about operationalizing the facilities during and after the COVID-19 pandemic. So that framework can be used. It's a beautiful way to address how are we going to see or handle non-COVID care in our hospitals. But you will need to have a plan in place. Without that, it won't work. Next is about the situational awareness and information sharing. I think as a country, we've done a fantastic job in terms of information sharing. You have daily updates about the cases and various other parameters that are being reported. The information technology network has been leveraged fantastically well. You have data being shared. You have each RT-PCR being tracked. So this indeed has happened, and this needs to happen in every such situation that we encounter. Provide dynamic forecasting of the functioning and sustainability of supply chain supported by the hospitals. So this is again based on the forecasting data that we get from, let's say in our example, from the various COVID-19 task force at the national and the state level. So we then tweak the supply chain and we address the requirements of PPE kits, of medications, of many things. And as we have seen earlier also, where the availability or the logistics becomes the key issue, like it happened with the oxygen supply or it happened with remdesivir or many other medications. The eventually the government comes into the picture and it puts a control on that, essentially to streamline the availability. Next, we talk about the mitigation of impact on critical care, and this is what we need to do. So, medically fragile patients need to be supported and protected by pre-event planning. Now, pre-event planning is, of course, we didn't do much of it when it happened to us in COVID-19 last year. But one way is that you reduce the reliance on hospital-based care. How do you reduce it? There are various ways of doing it. One of them is that you carry out monitoring using telemedicine. You encourage critical care at home. Various other methods are available. We can't go into too much of detail, but yes, the idea is to reduce reliance on hospital-based resources. Or obviously, because if you're talking about critical care for a pandemic situation, then you can't have critical care beds being consumed by patients who can be in some manner managed outside the hospitals. Then the local and the regional authorities be responsible for integration of community medical support in plans to treat medically fragile patients during the disasters. Now, we know that during the pandemic situation last year, we had a problem where the non-COVID care actually suffered a lot because the entire focus was on COVID care and the hospitals literally shut down for that reason. So this needs to be looked at as to how the patients who are medically fragile and not linked with the disaster that we are addressing, how they will get care. Given a situation where the mitigation measures fail, there are patients who can't be treated at home, your telemedicine is having a limited effect. So such patients will need to be given equal consideration for access to ICU resources. Now, this is something that is difficult to implement, tricky to implement, and will require expansion of ICU resources to a scale much bigger than sometimes a crisis requirements also. So a planning needs to be in place, but yes, beyond the point, I think there will always be limitation to provide equal access to ICU resources for a patient whose outcome of a disaster and the patient who is medically fragile for a different reason. Non-COVID hospitals, yes, we had designated non-COVID hospitals, but eventually they were also not sufficient in our experience at least. Planning for surge capacity for unique populations. So this is again important that hospitals should be able to provide initial stabilization care to unique populations. So when we talk about third care, we say pediatric population is going to be affected based on the forecasts that were there a couple of months back. Things obviously are always in evolution and change. So when you have this kind of a requirement that pediatric population needs to be addressed, and not every healthcare professional can handle a pediatric population, and therefore this is a unique population that you have large number of or anticipated large number of pediatric patients, but you don't have the skilled manpower to address it. Similarly, in a major fire incident, you will have burn patients. In a major industrial accident, you may have trauma patients. So these will have a specific skill requirement which may fall short during that period of responding to that event. So therefore, what we need is the access to regional expertise. You need to get resources from outside. So you get doctors from outside, medical teams from outside. Now this outside can be from outside the hospital, from outside that region, from other organizations, military, paramilitary organizations from other countries as well. So this is what is the requirement, that we get resources from outside. Secondly, you also need the experts also coming from outside, because obviously when you are expanding the care requirements, you will be expanding care requirements for everyone. So consultation, nursing care, paramedical equipment, paramedical staff and equipment, all will be required at a level more than the current or more than the normal requirements. This one is important, that service de-escalation and engineered failure. That means how do you shut down if you are not able to address some certain things. So the principle here is that you do an engineered shutdown, a planned shutdown, where the medical resources required for care of a small number of patients could be used for used to save greater number of lives. Now, this is exactly what is an altered standard of care, where you are denying care to a small number of patients in favor of larger number of patients who will benefit from that same material resource that you have. This can be in terms of number of staff or equipment or medicines or oxygen or whatever resource. So this is what is altered standard, and this needs to be discussed separately. I have limitation of time in this session today. So the hospital cessation of, so this is one situation where you, the first one is that where you realize that the material resources are required and they can be used to save larger number of lives than to provide critical care to a small patients, then you focus at larger number of lives to save the larger number of lives. The second is where the care providers themselves at a great risk. So when that happens, the care obviously is not to be provided. Now, this is again something that needs to be built into the policies of the hospital. This is something which will also require backing from the statute, so that the hospitals are protected from the negligence claims or care claims like that. So this is something that is not possible at the level of hospitals, but this is one of the principles which is described and defined in the text. So hospitals' decision to restrict or expand the delivery of critical care to be made as part of local or regional decision making, with the consultation and inputs provided by the hospital ICU leadership. So in every state, I think this aspect was implemented, where the total number of ICU beds were being monitored at the level of the local administration, and this information was also being made available through the social media and the other government channels and the media. So therefore, there was one attempt was to make the information available so that people can avail, and the second was also to shift patients from one place to another where the beds may be available. So this is something that was doable, and it was done also. The other two that we've discussed earlier are issues that need to be addressed, and they require backing from the statute or law. Now, towards the end of today's presentation, we come to what are the essential elements of a hospital surge plan. So the first one is to identify potential contingencies. And this we will need to look at the local context of the hospital. If you are in a coastal area, then you can have tsunami as one of your contingency defined. But the same is not true for a hospital which is in Delhi or Jaipur or Jammu or some such place. So what emergencies you identify or what contingencies you identify has to be applicable to you. And then for each of the identified contingencies, you must have following things in place. And these are the command and control, the communication structures, safety and security during the event, which should include how do you limit the visitor access, the triage requirements, the surge capacity, how much have you created, how are you going to expand, and how the resource will come. The continuity of essential services. So your essential services, for example, CSSD, linen services, your hospital kitchen, how are they going to function at a scale which is much higher than the normal working? The HR planning, how your staff is going to be put on duties, and the post-event actions. So these points are applicable to each of the identified contingencies that you have for your hospital. and you should have a separate provision for medical supplies. So there is a sample plan that I have given. There is an example of how you can calculate the medical supplies, easy way, and these medical supplies need to be segregated and identified. So you basically need a large disaster cupboard or a space where it is separately stored and periodically monitored so that it remains functional and useful when the time comes. And mock drills. We all know that mock drill is something without which we can't really function at the time of requirement. So mock drills are necessary. So there is a sample plan that will be shared, and you can download it. This video will be uploaded maybe by tomorrow morning, and similarly the other uploads will also be available by tomorrow because video needs a little bit of editing. So with that, it will be done. So thank you very much. If you have questions, then I'll attempt to answer. Yes. Any questions? So I can see the chat box. Surge in Taliban crisis in Afghanistan. Well, I think it is not a subject which is handled by the Research Foundation of Hospital and Healthcare Administration. So we will, for the moment, leave it to the to other people who are responsible for it. But how can the excessive need for oxygen be managed in the COVID crisis? Dr. Arneja, I think if you recollect how we managed it, initially, I think we suffered the lack of planning or lack of anticipation, if I can say, not planning exactly. So we didn't possibly anticipate that this will be a bottleneck for us. Therefore, the situation really became difficult. However, subsequently, the response was mounted, and there were a large number of steps that were taken by not only by the hospitals but also by the governments at various levels, and the oxygen was made available. This was essentially a supply chain issue. This was an issue where this was an issue of possibly bad management. I think if I can use this word, because the hoarding happened, which should not have happened. A lot of other things happened, which if they were anticipated, these things could have been controlled better. But I think we learned our lessons well, and the oxygen. I don't think in future we may land up in a situation of oxygen crisis. We may have a different crisis because we only learn in parts. So we may have a different crisis, but not the oxygen crisis. In view of two reasons why I'm saying. Many state governments have now mandated that the hospitals will have to have their captive oxygen capacity. So, for example, I can tell you that the UP government and the Delhi government have UP government has given a mandate and the Delhi government has given a guideline that hospitals must have a captive oxygen capacity based on the requirement that they themselves estimate. So they have not given a kind of how much quantity they should have, but they have said that you must have a captive capacity. And this is linked with the renewal of their annual their hospital registration. So eventually, every hospital will manage to get the additional capacity, and that shouldn't be a problem. We may land up with a problem of a different resource in future. That's a different thing altogether. Dr. Subramanian has asked, errors increased and nurse-patient ratio worsened during surge. Errors were mainly medication errors. Yes, sir. So this is something that needs to be considered. Now, that is where your altered standards of care, and I will strongly urge all of you today to have a look at this altered standards of care. We will also have a session on alternate standards of care. Even when a system is overwhelmed, when you have more number of patients than you can handle in the ordinary circumstances, then obviously there will be impacts. There will be medication errors. There will be many things that will happen. The patient safety will get compromised. The staff safety will get compromised. You will have many issues. So, so how do we address them? We can only address to some extent by planning, but I don't think you can really be immune to these things when you have a large scale event where the system really gets overwhelmed, there will be limitations of what care can be provided. Thank you very much. Surge capacity is something on which we are also in the process of planning a proper course, because one 40-minute presentation is clearly not sufficient for a topic of this nature. So I will, we'll see how it can be done. Whatever resource I have is being shared today, and that should be sufficient for the moment. Thank you very much, and see you next Saturday.